Hello and welcome to this revision video on CLL. This is aimed at other haematology registrars revising for the FRC path and is based on the ASH and BSH guidelines. What we will cover is pathogenesis, the IWCC criteria for starting treatment, first-line treatment, and what to do in relapse. CLL is a lymphoproliferative disorder of mature B lymphocytes. It requires the presence of more than 5 times 10 to the power of 9 of lymphocytes in the peripheral blood, sustained for at least 3 months. And the clonality of these B lymphocytes need to be confirmed by demonstrating immunoglobulin light chain restriction using flow cytometry. Somatic hypermutation takes place in the germinal center, which is a specialized structure found in the B cell follicles of lymphoid organs, where rapidly proliferating B cells accumulate after primary immunization. The defect of CLL occurs here and can indicate a benign cause. If the CLL defect occurs outside the germinal center, it can follow a more aggressive course of action. Fluorescence in situ hybridization FISH performed on peripheral blood of the lymphocytes can identify cytogenetic lesions in CLL cases, the most common being deletion of the long arm of the chromosome 13, 11, or 17. And furthermore, there can be specific genetic defects such as Notch signaling in ATM and TP53. CLL leukemic cells found in the peripheral smear are characteristically small, mature lymphocytes with a narrow border of cytoplasm and a dense nucleus lacking a nucleoli. There is also cellular debris found looking like smudge cells. A small percentage may have atypical pro-lymphocytic appearances, and if you have more than 55% of pro-lymphocytes with nucleoli, this would favour a pro-lymphocytic leukemia diagnosis. However, this remains difficult to comprehend as it's solely based on morphological criteria and there's no discernible immunological or genetic markers to identify. A significant proportion of circulating pro-lymphocytes of more than 10% seems to indicate a more aggressive form of CLL with Notch1 genetic changes or T53 aberrations. Most patients feel entirely well with no symptoms, and CLL is discovered on a routine blood count with absolute lymphocytosis, but some patients notice painless swelling of the lymph nodes with B symptoms of unintentional weight loss of more than 10% in the previous 6 months, fevers, night sweats, extreme fatigue. But as a clinician, you would start to think about treating the patient if they had significant symptoms from their lymphadenopathy, such as compression of airways, organomegaly, such as splenomegaly or hepatomegaly, and the presence of cytopenias, such as neutropenia, anemia, or thrombocytopenia. Cytopenias may be observed at diagnosis, which could indicate bone marrow function being replaced by leukemic cells, or a degree of autoimmune hemolytic anemia, which can be confirmed by direct antiglobulin Coombs testing, and very rarely can be because of pure red cell aplasia in 0.5% of patients, or autoimmune thrombocytopenia, which can occur in 2 to 3% of patients with CLL. Apart from peripheral lymphocytosis, immunophenotyping is the most important investigations with CLL cells expressing CD5, CD19, CD20, and CD23, as well as CD200. Each clone of leukemia cells is also restricted to the expression of either kappa or gamma immunoglobulin light chains. The expression of CD5 can also be observed in other lymphoid malignancies like mantle cell, but CD200, CD23, and kappa and gamma light chain restriction is usually sufficient to establish the diagnosis. Bone marrow is not essential at diagnosis unless someone develops cytopenias, and you would want to do genetic testing for TP53 and ATM prior to treatment. Alternative differentials would be hairy cell leukemia, mantle cell, marginal zone lymphoma, splenic marginal zone lymphoma, or follicular lymphoma, which will be discernible on immunophenotyping or biopsy. The Binet staging system is based on the number of involved lymphoid areas, which include head and neck, axilla, groins, palpable spleen, and palpable liver. Stage A is when the hemoglobin is above 100, platelets are above 100, and up to 2 of these areas are involved. Stage B is again the same denominations with 3 or more lymphoid areas, and stage C is when the hemoglobin is below 100 or the platelet count is below 100. In the Ray staging system, lymphocytosis, lymph node site, and splenomegaly is more important, with high risk being the evidence of cytopenias. Patients with leukemic cells that carry deletion 17 or TP53 mutations have an inferior prognosis and appear relatively resistant to standard chemotherapy regimens like alkylating drugs or purine analogues, but fare significantly better when treated with small molecule inhibitors of Bruton tyrosine kinase, PI3 kinase, or BCL2 inhibitors. CLL cells also use the immunoglobulin variable heavy chain genes that may or may not have undergone somatic hypermutation. The outcomes of patients with leukemic cells with unmutated IGHV genes usually have an inferior prognosis to patients who have a mutated IGHV gene. Normalization of beta-2 microglobulin at 6 months during treatment is also associated with an improved progression-free survival. Patients with asymptomatic early-stage disease should be monitored without therapy unless they have evidence of disease progression. Active disease should be clearly documented to initiate therapy, and at least one of the following criteria should be met. So there should be evidence of progressive marrow failure by the manifestation of cytopenias. The cutoff levels of a hemoglobin are less than 100, platelets less than 100. Massive splenomegaly, massive lymph nodes more than 10 centimeters, or progressive lymphadenopathy, and progressive lymphocytosis with an increase of over 50% over a 2-month period, or a lymphocyte doubling time of less than 6 months. Patients with initial lymphocyte counts of less than 30 times 10 to the power of 9 may require a longer observation period to determine the lymphocyte doubling time. Other complications like autoimmune hemolytic anemia or thrombocytopenia that's poorly responsive to corticosteroids may also be considered, as well as symptomatic extranodal involvement in the skin, lung causing pleural effusions, for example. Patients with CLL can have markedly elevated leukocyte counts. However, leukostasis rarely occurs in patients with CLL, so the absolute lymphocyte count shouldn't be used as an indication for treatment. The Nice Cancer Drugs Fund allows upfront venetoclax and omalizumab for fit patients who lack the TP53 mutation. There's no NICE approval for using a Bruton tyrosine kinase inhibitor, even though the E1912 study showed overall survival advantage of ibrutinib compared to FCR in this patient group. FCR, which is fludarabine, cyclophosphamide, and rituximab, can be used very well in patients with IGHV mutations and has a 50% cure rate. Studies have also shown that patients with IGHV mutations do better with the venetoclax and omalizumab compared to patients who do not have this mutation. In contrast, all patients with CLL and TP53 mutations are eligible for venetoclax, omalizumab, ibrutinib, acalabrutinib, and venetoclax monotherapy if a Bruton tyrosine kinase inhibitor is contraindicated. Acalabrutinib monotherapy and fixed duration venetoclax omalizumab are NICE approved for patients above 65. There's no evidence directly comparing these targeted agents in TP53 mutations to recommend one over the other. Frontline ibrutinib monotherapy is also NICE approved and funded in the UK for patients with a TP53 mutation, but not for other frontline patients. Acalabrutinib and ibrutinib have no difference in progression-free survival in this class of patients, but there is less toxicity with acalabrutinib with atrial fibrillation, arrhythmias, diarrhea, and bleeding. So in certain patients, the use of a more selective Bruton tyrosine kinase inhibitor such as acalabrutinib with fewer cardiovascular side effects may be preferable. Patients with cardiac disease should also be monitored closely using omalizumab, and patients on venetoclax treatment need an adequate renal function, and therefore patients with severe renal impairment, you may want to consider a broutine tyrosine kinase inhibitor. The current licensed therapies in relapse CLL are broutine tyrosine kinase inhibitors, ibrutinib and acalabrutinib monotherapy, or venetoclax monotherapy, or in combination with rituximab, or PI3K inhibitors such as idilizumab and rituximab. They can be used alone or in combination with rituximab as standard treatment options for relapse CLL, regardless of the presence or absence of TP53 mutations. No randomized evidence has ever compared broutine tyrosine kinase inhibitors versus venetoclax-based combinations in relapse CLL, so individualized treatment decisions are recommended, taking into account the patient's preference and toxicity profile. Allogeneic stem cell transplant is a treatment option for patients who are high-risk CLL, defined either by failing 2 out of the immunotherapy options, such as the broutine tyrosine kinase inhibitor or BCL2 inhibitors, irrespective of the TP53 status. And CAR-T therapy is only currently an option in clinical trials. One of the hallmarks of CLL is progressive immunodeficiency, characterized by impaired responses to vaccination, including influenza, pneumococcal hepatitis B, and varicella zoster virus. At diagnosis, pneumococcal vaccine is recommended, following at least 2 months later by the polysaccharide vaccine Pneumovax. The recombinant varicella vaccine Shingrix is safe for patients with CLL and is available in the UK for those aged 70 to 79. But live vaccines such as the MMR, live polio, yellow fever, and varicella vaccine Zostavax should not be given. During clinic, you should also consider antibacterial prophylaxis for all patients with a history of recurrent or serious bacterial infections. For patients taking a broutine tyrosine kinase inhibitor, PCP prophylaxis is recommended either throughout therapy or for at least the first 12 months. For patients on a fixed duration of treatment, such as Venar or Veno, prophylaxis may be considered for at least 6 months after the end of treatment or until the CD4 T-cell recovery. Prophylaxis with azoles is not routinely recommended with a broutine tyrosine kinase inhibitor or venetoclax due to potential drug interactions, but there have been reports of invasive fungal infections in patients receiving acalabrutinib or ibrutinib. Hypogammaglobulinemia is a common finding in patients with CLL. An IVIG replacement therapy is advised for patients who suffer recurrent severe bacterial infections despite 6 months of continuous oral antibiotic therapy, or have a total IgG of less than 4, or have a documented failure to respond to a polysaccharide vaccine challenge. Thank you for listening to this revision video on CLL. If you have any comments or suggestions, please contact me in the comments below.